Hi friends, welcome to my channel. So this is the part 3 of the series Care of Patients in Venti. We will see then in previous two videos we have seen what are the different care that we need to take in patients who are on ventilator, and how to means what are the thick supplies, then what are the means management strategies, how to means check all the monitoring of all the parameters of the patient who are on ventilator, about the different pain assessment scales or the sedation scales which are there. So in this video we will see about the suctioning part and how to manage the airway and all. Suctioning is a very important nursing care in mechanically ventilated patients. So suction is not routine. It should be done as needed. Always hyperoxygenate the patient before suctioning, because to prevent oxygen desaturation. And this is a common practice in means in the settings, hospital settings, that whenever the secretions are not coming, they instill some normal saline, but this should not be done. Either secretion removal should be done with the help of nebulization, chest physiotherapy, or an acetylcysteine can be used for that. And limit suctioning pressure to the lowest level as needed to remove the secretions. Okay, if the secretions is very thick, so you might need more pressure for its removal. Otherwise minimal secretions is there, no, always try to suction it at a lower pressure, and suction for the shortest duration possible. It should not be more than 10 seconds. Then how to estimate the correct suction catheter size on endotracheal tube. So always multiply whatever the ET tube size is there, 7, 6, like that. So for example, the ET tube size is 8. So multiply 8 with 3, you will get 24. Then divide this 24 by 2. So always the suction catheter size should be half of that of the ET diameter. Okay. So half or less than the ET diameter. So like if 8 is there, so you should take 12 size suction catheter. Okay, 12 French suction catheter should be used. Then what are the suctioning levels? Okay, in adults it is around 100 to 120. Okay, in case of open suction. In closed suction it is around the limit can be around 160 mm of Hg. This is the maximum in 120 in open suction. In closed suction 160. Okay, and maximum suction till 150 also it can be there in open suction. Then child 80 to 100. Okay, maximum can go up to 125. Infant 60 to 100, maximum till 100 it can go. Then there are two types of suctioning methods. One is open suctioning, another one is the closed suctioning. Open suctioning is always sterile procedure. Okay, so here you have to disconnect the patient from the ventilator for some time, and then you have to do the suction. And always suction, while suctioning you have to move in a circular motion. Okay, in a circular motion you should move in, and don't apply suction while moving in. Okay, always apply suction while taking it out. Okay, first you have to insert the suction catheter into the endotracheal tube, then withdraw it. When there is a gag reflex, withdraw it uh, 1 to 2 centimeter, so that it does not hit the carina, otherwise the patient can have bradycardia. So pull it 1 to 2 centimeter and then suction it in a circular motion, in a pin rolling method. You have to suction it and move out, and again connect the ventilator, and then oxygenate the patient. Give some time, about 2 to 3 minutes, for the patient to get back to its saturation, and then again if secretions are there, you need to suction the ET tube. Then it is open suctioning is not recommended when the PEEP is more than 10. Okay, and closed suction when the patient is having more secretions, or the patient is a TB patient. Okay, or any kind of MRSA infection is there, so in those cases you need to use the closed suction method. And also if the patient is having ARDS or the PEEP is very high, by opening the suction, the patient will loss of PEEP will be there. So in those cases closed suctioning should be used, and it is a clean procedure. From outside the tubing is present inside a polythene like bag, is there, and you have to insert it in the ET tube, pull it, do the suction, and take it out. And also there is a flush line is there. So in order to flush the catheter, always flush the catheter pre or post intubation, means while suctioning, okay, in order to clear the secretion. Otherwise, whatever secretions you are taking in the tube, again you will be inserting it inside. Next, based upon the sputum color, you will be able to assess what are the means associated problem that might be there. Like yellow means presence of pus white blood cells and possible some infection is there. Green thick means the patient might be having some airway infection or breakdown may be there of mucopolysaccharides, a component of sputum. Then green foul smelling means any pseudomonas infections might be there. Okay, if there is a pink tinged means fresh blood is there. So this means if pink tinged sputum is there, means it is a fresh blood. Okay, so it can be decreased with the help of aerosolized adrenaline, means epinephrine can be used in the nebulization, or isoproterenol can be given. Then if fresh blood is present, means it suggests that the patient has any airway trauma or pneumonia or pulmonary infarction or emboli. If there is brown secretions, means it means there is old blood which is present. And if rusty color is there, means the patient might be having Klebsiella infections, might be there. Pink copious or frothy sputum means the patient might have some pulmonary edema, might be present. So these are the, based upon the sputum color, you might identify what is the potential problem in the patient. Then these are the indications of closed suction, like if the patient is hemodynamically unstable, and you should not disconnect the patient from the ventilator. High PEEP is there, okay, high FiO2 is there, hemodynamically unstable, or the patient is get desaturated while suctioning, or any contagious infections are there, or if the patient has who require frequent suctioning more than 6 times a day, or a patient receiving inhaled gas mixture such as all this oxide or heliox that cannot be interrupted while ventilator connection. So this is used in anesthesia and all. So in those cases, closed suctioning should be used. Then this is very important, that is check the ET tube and the tracheostomy tube. Always while in the ICUs, always check the ET tube placement. Okay, so this will help to prevent, means the ET tube should not be more inside the lungs, otherwise it will go towards the right side, because right side bronchus is more, means it is curved, means it is more straight, so the ET tube has chances that the ET tube can get into the right side, and the left side lung can get collapsed. So always check the to at what means the placement of the ET tube. So in case of women, it is 21 centimeter from teeth in women and 23 centimeter from teeth in men. And always check the tip of the ET tube in the X-ray. Okay, it should be 3 centimeter above the carina. Okay, 21 to 22 centimeter, 22 to 23 centimeter is for men. Other complications of tracheostomy tube include tube dislodgement, bleeding, infections. To identify these complications, always assess the insertion site, breath sounds, vital signs, and the PEEP trends. Okay, so these all things need to be checked. VAP bundle. So you have heard about it, that is ventilator associated pneumonia bundle to prevent infections. So keep the head end of the bed elevated to 30 to 45 degree. Okay, it should be between this. It should not be more than that or less than that. Okay. So healthcare provider tend to overestimate bed elevation, so gauge it by looking at the bed frame rather than by simply estimating. Okay, in the bed there is a measurement device is there which will help to identify whether it is 30 degree, 45 degree, or more than that or less than that. Every day provide sedation vacations. Okay, and assess the readiness whether the patient will be get able to extubate or not. Check the vital signs EBG of the patient. Peptic ulcer prophylaxis is very important for these patients because these patients can get ulcer if PPIs are not given to these patients. Then DVT, because they can't mobilize, so DVT prophylaxis should be given either in the form of medications like LMWH or mechanical DVT prophylaxis. DVT stocking should be given, and oral care with chlorhexidine mouthwash daily should be provided. Then other methods to prevent VAP is like performing range of motion exercises, changing the patient position every 2 hourly so that the muscle disuse can be prevented. Patient sit-ups should be there to improve the gaseous exchange. Appropriate nutrition should be given to prevent the catabolic state, and assess the patient tolerance when she performs an activity by checking the vital signs, oxygenation status, and pain and agitation levels. So if the patient is getting mobilized, so check the vitals of the patient while doing. And brush the patient's teeth at least twice a day and provide oral moisturizers every 2 to 4 hours if possible. Coming to prevent hemodynamic instability. So monitor the patient's blood pressure every 2 to 4 hours, especially after ventilator changings have changed or being adjusted. So because in mechanical ventilation, as these are positive pressure ventilators, so the thoracic cavity pressure may be more. So if the thoracic means the intrapleural pressure or the intrathoracic pressure is more. So when the intrathoracic pressure is more, what happens? There is a it puts pressure on the blood vessels and it can reduce the blood flow to the heart. Okay, so when during inspiration, as we know, there is blood means venous return to the heart from the lower part of the body to the heart. So when the intrathoracic cavity pressure is more, so the blood is not able, the venous return is very less, and also the blood which are present in the thoracic cavity in the blood vessels, so they are also not able to means deliver blood to the heart. So this may drop the blood pressure of the patient. So always have a look at the blood pressure. And to maintain hemodynamic stability, you may need to increase the IV fluids or administer the drugs such as dopamine or norepinephrine dobutamine as ordered. And high levels of inspiratory pressure with PSV and PEEP increase the risk of barotrauma and pneumothorax. So always check this. To detect this complication, assess the breath sounds and oxygenation status often. Okay, so PSV and PEEP, if it is more, so it can cause barotrauma and pneumothorax can be there. So always check the breath sounds of the patient and the oxygenation status. Okay, so if there is a collapse or any trauma is there in the alveoli, so this may cause decreased breath sounds and oxygenation. So in the ABG, you will find that PaO2 levels are decreasing. Coming to the management of airway, so the cuff in the endotracheal tube provides the airway occlusion. It provides two benefits. One is it does not allow the means migration of the tube further down, or it does not allow the dislodgement of the tube. And one more thing is it does not allow the secretions to get into the lungs. Okay, so proper cuff inflation is very much important uh, for the patient, and to receive the proper ventilatory parameters, tidal volume, and the oxygenation. And always reposition the ties and secure the ties every 4 hours to prevent the risk of any tissue damage to the lips. Okay, so ties should be replaced every 24 hours. Repositioning should be done 4 hours, and so that damage to the lips should be not be there. And while repositioning, you need to check at what level you are fixing. Okay, at what level you are fixing the ET tube, that needs to be checked and replaced every 24 hours. And the ties that you are using, it should be replaced every 24 hours or when a new tracheal tube is placed. Then what are the different other managements of the artificial this airway? So aspects of tube placement should be taken care of, tube security and cuff status. Incorrect tube placement can cause ineffective ventilation, and which can result in esophageal intubation can also be there. So always check the tube placement, that is too high or too low in the trachea, it should be checked. Subsequent displacement of the tube, however, may result from head flexion. Okay, while flexing the head or giving morning care to the patient, or tension during transport, or swelling of surrounding tissues, what may happen? There can be displacement of the tube. Either it may go more inside or it may come out. So this things need to be checked. So therefore the level of the ET tube should be checked properly, and if there is any displacement, always properly place the tube and tie it with the help of the ties. Then verify the placement with the help of 5-point auscultation method. Okay, I will show you the picture what is 5-point auscultation. So after the tube placement, always auscultate the lungs whether both the lungs are getting equal ventilation or not. End tidal carbon dioxide monitoring and radiological examination are very important after the placement of the tube. And chest radiograph is the gold standard method for identifying whether the tube is in place or not. And measure the cuff pressure to ensure that it should be within 25 to 30. Okay, within 25 to 30 it should be there. It should not be below that. Sorry, it is not below. It should be between 25 to 30. Okay, and during a cuff leak, air should never be added blindly as it can cause vocal cord injury. Okay, during a cuff leak test, air should not be added blindly as it can cause vocal cord injuries can occur, because if the cuff is means if the cuff is displaced and it is placed in the vocal cords, and if you are blindly pushing air and if you have not checked the placement of the tube, so it can cause vocal cord injury. Always check the placement and then do the cuff leak test and all. So cuff leak test means when the patient is means if you want to extubate the patient, before that we do the cuff leak test, in which we deflate the cuff and we check for any laryngeal edema is present or not. So the exhaled tidal volume which is there, it should be uh, 1/3 of the tidal volume that was present before the cuff was deflated. Okay, so this should be checked. So that is the cuff leak test. So this is the 5-point auscultation method. So that is right infraclavicular, left infraclavicular, right inframammary, left inframammary, and the gastric. Okay, epigastric. So these are the 5 points that need to be auscultated. So gastric, why gastric? Because we want to know whether any means whether the intubation has been mistakenly done in the esophagus, and whether any sound is coming or not from the gastric part. So therefore gastric is also auscultated. So these are the five points of auscultation. So this is the cuff manometer. So this is a pilot balloon which is connected to this cuff manometer, and it should be between this green part that you are seeing, that is the safest part, means within 20 to 30 or 25 to 30 it should be present. You can determine the ET tube cuff size by using this formulas. So this is for cuffed, this is for uncuffed. Humidification, always check for the adequacy of humidification. So the humidifier is the ideal medium for bacterial growth. So always change the HME filters every 24 hours. It should be changed. So this is a HME filter as I have shown you earlier. So this is a tracheostomy vent, means thermovent. This is a HME filter for tracheostomy tubes. Okay. Here oxygen port is there, suctioning port is also there. So this is connected towards the tracheostomy tube. Then coming to the patient's nutritional needs, when the patient is on ventilator, so the nutritional needs can't be met through orally, so through RT tube only it has to be given. So therefore feeding is very important. So a best outcome is for patients receiving moderate rather than high calorie intake, 9 to 18 kilocalorie per kg per day, And before giving feed, always aspirate whether the previous feed has is present or not. Okay, so if it is present, wait, or you can give you can inform the doctor and give injection metoclopramide, and after that again check in the next feed whether the patient is able to tolerate or not. If it is not, then inform the clinician. If continuous feed has to be started, then it should be done. Regularly assess for any abdominal discomfort or distension, presence of bowel sounds, amount of characteristics of gastric aspirates, what is the color, any smell or what is the smell, and frequency of bowel movement should be checked. Then preventing injuries to the skin. So as mechanically ventilated patients, if they are sedated, then they can't move. So proper positioning is needed, and this ventilated patients cannot move away from the heat, so there is high risk for thermal burns can be there. So always check the patient's bed and all. Eye care should be given. So the patients who are sedated, they may have some corneal ulcers, so lubricant should be used to prevent keratopathy. Bladder management, urine output should be checked. It should be 0.5 1 to 2 ml per kg per hour. If less than 1, then the clinician should be notified for that, and the urinary catheter placement should be checked, okay, whether it is in proper place or not, or whether any kinking is present. So all these things need to be checked. Educate the patient and the family about all these things, means what are the cares that are being provided, about the lab tests and x-rays, what is the progress of the patient, so that family can also get involved in the care. Coming to the ventilator weaning, so when the patient status is slightly improving, and we are um, and the clinician is ready to extubate the patient, so we have to wean the patient. So weaning is a word that mainly describes the process of gradually removing the patient from the ventilator and restoring the spontaneous breathing after a period of mechanical ventilation. So there are different methods of weaning, that is rapid ventilator discontinuation or spontaneous breathing trials, which are like SIMV, PSV, T-tube trial, CPAP. So this we will discuss in the mechanical ventilator video. Then role of nurse during weaning. So always wean during the day, not at night. So because at night the patients are drowsy, so it should not be done. Remain with the patient during initiation of weaning and elevate the head end of the bed, and the patient should be upright during the weaning or during or after weaning when extubation is going to be there. So during extubation also ensure patent airway and suctioning should be done. Provide rest period on ventilator for 15 to 20 minutes after suctioning. Instruct the patient to relax. Monitor all the respiratory rate, vitals of the patient, accessory muscle frequently. Use of accessory muscles if any is present or in diaphoresis. And also after the extubation, keep nebulization machine. So when the weaning is successful, then you need to extubate the patient. So at that time, you need to keep the suction ready. If before that, if you want to do the cuff leak test, you can also do that. And nebulization machine should be kept ready. And before extubation, suction inside the ET tube, then the oral suction should be there, and then extubate the patient and keep the patient on nebulizing machine with either adrenaline or NS. Okay, and also provide adequate ventilation should be there, and patient should be kept upright. And after extubation, give oral care to the patient and keep the patient NPO for some time, and after that um, give feed to the patient if the patient is able to tolerate through RT or through orally, okay, as per the patient. If signs of fatigue or respiratory distress develop during the weaning process, discontinue the weaning trials. Okay. Next, there are certain causes of air problems that can lead to certain respiratory distress. like tube migration, as I've told you, migration of ET tube above the vocal cords, or right mainstream bronchus, rupture of the ET tube, ET cuff, kinking of the tube. So all these are some of the problems that can be there and can cause sudden respiratory distress in the patient. Then management of sudden severe respiratory distress in a mechanically ventilated patient if it occurs. Disconnect the patient from the ventilator. Begin manual ventilation using self-inflating resuscitation bag containing 80 to 100%. Maintain normal ventilator parameters, pressures, and use a PEEP attachment if the patient has been on high PEEP. So if the patient has any respiratory distress, or if there is any ventilatory failure, you should disconnect the patient from the ventilator and use bag and mask ventilation. Bag and mask do not be used. In that case, you can use a Bain circuit for the ventilation of the patient, and manually evaluate the compliance and the resistance through bag ventilation. Okay. Perform rapid physical assessment and assess monitored indexes and alarm, and check the patency of the airway by passing a suction catheter. If death appears imminent, treat the most likely problem like pneumothorax or airway obstruction if any present. Once the patient condition has stabilized, perform a more detailed assessment and provide an additional treatment. So whenever the patient is in distress or the mechanical ventilator failure is there, means any kind of operational failure is there in the ventilator, so in those cases you should disconnect the patient from the ventilator and use a Bain circuit for ventilating the patient, and manually check the compliance and the resistance. Listen for lung sounds. Physical examination should be done, and also check the patency of the airway, whether the ET tube has become means blocked by the mucus secretions or not. So all these things should be checked. And if there is some pneumothorax or airway obstruction, so that should be treated as fast as possible. So these are the management in a sudden severe respiratory distress. And this is the last slide, and this is the last part of this series, that is care of patients in Venti. So I hope you like the videos. So please watch these videos, and if you have any suggestions or if any extra points that you need to add, feel free to comment below. So thanks, and have a good day.